Hello everyone, welcome to Module 40 on Basic Concepts of Psychological Disorders. This is where we will begin to review uh, the background information that's necessary for us to look at some specific disorders in Modules 41 and 42. So the question is how do we draw the line between normality and disorder? According to psychologists and psychiatrists, psychological disorders are marked by a clinically significant disturbance in an individual's cognition, emotion, regulation, or behavior. Such thoughts, emotions, or behaviors are dysfunctional or maladaptive. They interfere with our normal day-to-day life, and the dysfunctional person is often distressed. 40-2, how do the medical model and the biopsychosocial approach influence our understanding of psychological disorders? In earlier times, abnormal behavior was attributed to strange forces, such as the movement of the stars, godlike powers, or evil spirits. During the Middle Ages, it was commonly believed that abnormal people were possessed by devils. Therapy often involved physical and mental torture. Philippe Pinel recognized abnormal behavior as a sickness of the mind. He opposed barbaric treatments of patients, and he introduced and encouraged reforms and humane treatments. So if we look at yesterday's therapy, through the ages, psychologically disordered people have received brutal treatments, including the trephination evident in this Stone Age skull. Drilling skull holes like these may have been an attempt to release evil spirits and cure those with mental disorders. It looks doubtful that this patient would have survived the cure. In the medical model, in the 1800s, the search began for physical causes of mental disorders and for curative treatments. With the medical model of mental disorders, mental illness is to be diagnosed on the basis of symptoms and treated through therapy, often in a psychiatric hospital. Reinvigoration of the medical model has come from recent research in genetically influenced brain abnormalities in brain structure and biochemistry. So the medical model is looking exclusively at our nature. In contrast, the biopsychosocial approach looks at things from a more holistic perspective. It's a general approach positing that biological, psychological, and social-cultural factors all play a significant role in human functioning in the context of disease or illness. Some symptoms of disorders are culture-related, which points to environmental influences. For example, the eating disorders anorexia nervosa and bulimia nervosa occur mostly in food-abundant cultures. Depression and schizophrenia, however, occur worldwide. In the biopsychosocial approach, disorders reflect a genetic predisposition and physiological state, psychological dynamics, and social and cultural circumstances. The biopsychosocial approach emphasizes that mind and body are inseparable. The biopsychosocial approach also considers the role of epigenetics, which is the study of environmental influences on gene expression that occur without a DNA change. Epigenetics shows that our environment can affect the expression or not of a gene, thus affecting the development of psychological disorders. In this chart, which is very familiar throughout the Myers text, we look at the biological influences, psychological influences, and the social cultural influences that impact a psychological disorder. In the biological influences, we look at evolution, individual genes, brain structure, and chemistry. In the psychological influences, we look at stress, trauma, learned helplessness, mood-related perceptions, and memories. And the social cultural influences, we look at roles, expectations, and definitions of normality and disorder. 40-3. How and why do clinicians classify psychological disorders, and why do some psychologists criticize the use of diagnostic labels? Classification orders and describes symptoms. Diagnostic classification in psychiatry and psychology attempts to predict the disorder's future course, suggests the appropriate treatment, and prompts research into its causes. The most common tool for the system of classifying these disorders is the Diagnostic and Statistical Manual of Mental Disorders, now in its 5th edition, or the DSM-5. This is published by the American Psychiatric Association, and it describes disorders and estimates their occurrence. In the new DSM-5, some changes include some label changes. For example, autism spectrum disorder and intellectual disability are changes in labels, new categories such as hoarding disorder and binge eating disorder, and newer altered diagnoses, some which are controversial, for example, the concern that simple bereavement may be too quickly diagnosed as a depressive disorder. In classifying disorders and labeling people, the DSM has some criticisms. Critics have long faulted the DSM for casting too wide of a net when it comes to talking about what is a disorder and what isn't. Antisocial personality disorder and generalized anxiety disorder did poorly on field trials for the new DSM-5, that is, using the criteria for diagnosing individuals with the disorders. The DSM-5 continues the path of potentially pathologizing everyday life. Labels are and may act as society's subjective value judgments. However, there are some benefits of the DSM, which is helping mental health professionals communicate. It is useful in research, and clients are often relieved to identify their suffering. 40-4. Why is there controversy over attention deficit hyperactivity disorder? Attention deficit hyperactivity disorder, ADHD, is marked by extreme inattention and/or hyperactivity and impulsivity. 11% of Americans 4 to 17-year-olds receive this diagnosis after displaying its key symptoms. 2.5% of adults have ADHD symptoms. Critics fear this disorder is overdiagnosed, leading to overuse of prescription drugs. And there is an interesting study where client cases were mailed out to psychiatrists around the country or in a specific geographic area to find out whether or not the individuals would diagnose the case with ADHD, and there was a high percentage of false diagnoses in those cases when they were returned. Those who say ADHD is overdiagnosed argue symptoms displayed sound like the disorder of having a Y chromosome. ADHD is 3 times more prevalent in boys than girls. ADHD may in effect be marketed by companies that often provide drugs for its treatment. One person said that Ritalin and ADHD had almost the same birth time. An energetic child in a boring school, would this equal an ADHD diagnosis? An alternate view of those arguing that ADHD is not overdiagnosis is more frequent diagnoses due to increased awareness of disorder. The scientific community agrees ADHD is a real neurobiological disorder. It coexists with learning disorders, it is heritable, and it is treatable with medications. There is debate over the safety of long-term use of these stimulant medications in treating ADHD. There's also some other evidence that exists. ADHD is partially related to developmental delay. So as an individual matures and their brains mature, such as they reach the age of 24 or 25 chronologically, sometimes these symptoms become less intense than they are at earlier age. Are people with psychological disorders dangerous? 40-5. Do psychological disorders predict violent behavior? Mental disorders seldom lead to violence, and clinical prediction of violence is unreliable. Most people with disorders are nonviolent and are more likely to be victims than perpetrators of violence. When they are violent, moral and ethical questions about whether society should hold people with disorders responsible for their violent actions are raised. Triggers for violent acts by people with mental disorders, in addition to disordered thinking, also include substance abuse. 40-6. How many people have or have had a psychological disorder? Is poverty a risk factor? The U.S. National Institute of Mental Health estimates just over 1 in 4 adult Americans suffer from a diagnosable mental disorder in a given year. Psychological disorder rates vary by time and place. The immigrant paradox: those born to immigrants to the United States are at greater risk of mental disorder than immigrants, for example, Mexican Americans born in the U.S. Poverty is a risk factor when discussing psychological disorders. The incidence of serious psychological disorders has doubled. Conditions and experiences associated with poverty contribute to the development of psychological disorders, but some disorders, such as schizophrenia, can drive people into poverty. Correlation goes both ways, and in this case we realize a relationship between two variables does not mean that one causes the other. Psychological disorders usually strike by early adulthood, first symptoms by age 24 in most cases, and as stated previously, this is the age when it is thought our brain, the physical structure of our brain, is cognitively mature. Symptoms arrive at the following median ages, and the median is the midpoint in the range. Antisocial personality disorder around age 8, phobias around age 10, alcohol use disorder near age 20, obsessive compulsive disorder near age 20, schizophrenia near age 20, and major depressive disorder age 25. This chart from the Myers text lists the percentage of Americans reporting selected psychological disorders in the past year. That we have generalized anxiety is about 3.1%, social anxiety is 6.8%, phobias of a specific object or situation 8.7%, depressive disorders or bipolar disorder 9.5%, obsessive compulsive disorder 1.0%, schizophrenia 1.1%, post-traumatic stress disorder 3.5%, and attention deficit hyperactivity disorder ADHD 4.0. There are a lot of things that can increase our vulnerability to mental disorders. There are risk factors as well as protective factors that we can engage in. And the list of risk factors includes academic failure, birth complications, caring for those who are chronically ill who have a neurocognitive disorder, child abuse and neglect, chronic insomnia, chronic pain, family disorganization or conflict, low birth weight, low socioeconomic status, medical illness, neurochemical imbalance, parental mental illness, parental substance abuse, personal loss and bereavement, poor work skills and habits, reading disabilities, sensory disabilities, social incompetence, stressful life events, substance abuse, and traumatic experiences. Protective factors against developing a mental disorder are aerobic exercise, a community that offers empowerment, opportunity, and security, economic independence, effective parenting, feelings of mastery and control, feelings of security, literacy, which is very interesting, to see that the literacy rates actually are a protective factor against mental disorders, positive attachment and early bonding, positive parent-child relationships, problem-solving skills, resilient coping with stress and adversity. This is also referred to as grit by Angela Duckworth. Self-esteem, social and work skills, and social support from family and friends. This brings us to the end of Module 40. In Module 41, we will start to look at specific disorders in more detail.